All right, well, we'll go ahead and kick it off. Hello, everybody. My name is Joanna Phillips. I am the physician liaison for Northside Hospital Gwinnett and Northside Hospital Duluth. And you're joining us today for our Wellness Wednesday presentation that we have. We do this approximately once a month. Sometimes we do it 2 times a month. It just depends on what all we have going on. But I'm just glad you joined us today. So just a couple housekeeping notes. If you didn't already hear me or if you weren't on when I said this a moment ago, if you could mute your line, that way we don't hear any background noise. And then throughout the presentation, if you do have any questions or things that pop into your head you don't want to forget and wait until the end, you can certainly use the chat option at the bottom of your screen and type something in. I'll be monitoring that throughout, and then when there's a pause in the presentation, I'll interject that to Dr. Tugbiyele so he can address that, or you're welcome to just save your comments and your questions toward the end as well. So we'll do it that way. So without further ado, I'll introduce Dr. Stephen Tugbiyele. He is our newest provider with Northside Center for Urogynecology. The practice itself is relatively new. Dr. Tugbiyele joined in April, and he's going to talk to us about the field of urogynecology, kind of give a little bit of background and what is it and why is it such a fantastic specialty, particularly for us women. So without further ado, I will pass it off to Dr. Tugbiyele.
Thank you, Joanna. Wonderful. And hello, everyone who's joining and those who will join either virtually or later on. It's a pleasure being here. Thank you so much for your time. And my goal is to make this as valuable and as informative as possible for you, okay? And for the people that you'll be sharing this with. So let me see here. Okay, so Joanna, in the middle of my screen, there's a little bit of an icon here. I'm not sure if you're able to remove it. It says this meeting is being recorded, but let's see here. Okay. So we'll just kind of work around that. Okay, so just a little bit about myself. I originally from New York City. I trained at New York University School of Medicine and graduated 20 years ago, seems like yesterday. But then after finishing medical school, I then stayed at NYU for residency, so a 4-year residency in obstetrics and gynecology. And then afterwards, I completed a 3-year subspecialty fellowship at the University of Maryland and Greater Baltimore Medical Center in urogynecology. And then afterwards, I practiced in the Northeast for over 12 years, where I did so many, amongst many things, pioneered a robotic surgery program. My field of specialty is in robotic laparoscopic and vaginal surgery, essentially minimally invasive surgery. Numerous awards, but most recently Atlanta Top Doc last year and the year prior. So I'm really excited to be here to be able to share some up-to-date leading edge information that will really improve the quality of life of women as a urogynecologist. So what is a urogynecologist? A urogynecologist is a subspecialist who is essentially a surgeon who specializes in the pelvic floor health of women. And we take care of women who have pelvic floor disorders. And what is a pelvic floor disorder? Well, namely pelvic organ prolapse, urinary incontinence, and a number of different conditions. When we say prolapse, it doesn't mean that either the uterus, the bladder, the vagina in a woman who's had a hysterectomy, or the rectum is bulging in or out of the vagina. Or urinary incontinence, is it accidental leakage of urine, depending on when that occurs, accidental leakage of stool, fecal incontinence, either acute or recurrent urinary tract infections, pelvic pain, fistula, which is an abnormal connection between several areas in the pelvis that may result in either urine coming through the vagina or stool coming through the vagina, difficulty with emptying the bladder or bowel, so that's voiding or defecatory dysfunction. As a urogynecologist, we also take care of women who have had gynecologic surgery and they've had a complication as a result of that. And so we are the specialists who also help to manage that and help to correct those complications. Interstitial cystitis, bladder pain, as well as any injury a woman sustains due to having childbirth. So we are subspecialists who, again, we either take care of women who in the office or in the operating room for a number of conditions that affect the woman's pelvic floor. So one of the two objectives for today's talk is to also just give you an idea as to what a urogynecologist manages and what is the benefit of seeing a urogynecologist and how we can improve a woman's quality of life. So as I mentioned before, we have completed medical school as urogynecologists and did a 4-year residency in obstetrics and gynecology. There's some urogynecologists who have trained through the urology route, and they also then have to undergo subspecialty training. So in addition to our residency training, we undergo subspecialty training in urogynecology, female pelvic medicine, and reconstructive surgery is also the other official board name for our subspecialty. We assess the interconnection of the bladder, the pelvis, and how the nerves, blood vessels, connective tissue, organs all work in sync to help to support a woman's pelvic floor. And as urogynecologists, subspecialists, we have the knowledge and of the latest research and leading treatment options that can help improve a woman's quality of life. So what is the pelvic floor? The pelvic floor is a set of muscles, ligaments, connective tissue in the lowest part of a woman's pelvis that supports her organs, the bladder, the bowel, the uterus, the vagina, the rectum. And so all of these work in sync to help to connect, help to support a woman's pelvic floor. And so as I mentioned before, pelvic floor disorders, if there's something that goes wrong with the pelvic floor due to weakening of the muscles or weakening of the connective tissue, it could be tears. I always say that, gravity is not our friend, and there are different risk factors for pelvic floor disorders. Living life long enough, aging, and childbirth, menopause, weakening of the muscles due to lowered hormone levels, chronic disease, for example, women who either smoking or a pulmonary condition that places more stress on the pelvic floor due to chronic coughing, previous pelvic surgery, which interrupts the connections of the bladder and the ligaments and the uterus, and genetics. There are some women who are more at risk for pelvic floor disorders, depending on, we know that Caucasian women are at risk for a greater risk for prolapse, and African-American and Latina women are at risk for urinary incontinence. And there's a lot of genetics in there. Oftentimes our moms and our sisters dictate what will happen to us. And so the genes dictate how the nerves and the muscles work together. And later on in life, that can play a role. So this is quite common. And when patients come to see me in the office, I like to, first of all, allay her fears and reassure her that she's not the only one, that these are conditions that affect many, many women, and that she's not alone. A lot of women talk about things, but this very thing is embarrassing, it's uncomfortable, it's bothersome. And so this is not something that women, volunteer readily. But once we get over that barrier, that woman knows that she's not alone, there are good options that are safe and effective and that work, typically then she's more open to talk about it. We get over that barrier, and then we talk about options that are safe and effective and how we can improve a woman's quality of life. And so that's essentially what we do as urogynecologists. We're not trying to make things better. We may not be able to make things perfect, but there are a lot of options that women have to definitely make things significantly better. And we're gonna get into those options now. And these things affect not just quality of life, but body image. Women want to feel, they want to feel well, and they want to feel like themselves, and they want to feel alive and do the things they enjoy. And oftentimes these kind of conditions affect a woman's ability to enjoy her life. So prolapse. Prolapse is the loss of support to the female pelvic organs, either the muscles, connective tissue, or the nerves. It can involve the uterus, the cervix, the bladder, the rectum, or a combination of things. The lifetime risk of this occurring to a woman is significant, and it's about 30% of women who may develop prolapse in their lifetime, but up to 11% of women, if not higher, may require surgery for this. So, when a woman does choose surgery, there are a lot of different options. There are non-surgical options and there are surgical options, but when a woman chooses a non-surgical option, it's very important that she sees a urogynecologist, because we manage this week in, week out. So what are some of the symptoms that women feel? She may feel pressure, heaviness, or dullness, something like this, something's falling out of the vagina, a dragging, dull ache, either in the lower pelvis or in the back, is what women have told me over the years. Vaginal pressure, splinting, which is inserting a finger into the vagina or supporting the perineum to have a bowel movement or to empty the bladder. And it significantly impacts quality of life and body image. So we have here on this screen different pictures of the pelvic floor. And one of the pictures is one where it's a normal picture where I wish I could point to it. Oh, it's not letting me do that here with my pointer. So I would just say that the upper left-hand corner is a normal picture. And then on the right hand, right across from it, the bladder is sinking down. So the bladder's in the front, the rectum's in the back, and then the uterus and the cervix is kind of in the middle. So we're looking at women from a side profile. When the bladder drops, that's called a cystocele. She may feel pressure not being able to empty her bladder, as having to lean forward to empty the bladder, or press in the low pelvis to empty the bladder. Pain, feeling like the urine stream is really slow. It's taking her a long time to empty. And then when we go down across, we see where there's a rectum that's bulging up into the vagina, and this is called a rectocele. And a lot of times women will feel pressure there, difficulty emptying the bowel, constipation, and a bulge. And then lastly, the uterus or the womb, where menstruation, and women who've had children carry their children, that's where the uterus is sliding down. And again, that's like a bulge or something there that shouldn't be there. So when a woman comes and sees me, oftentimes she said, wow, like it was in the shower, or she, just all of a sudden noticed it. And it worries her, is this a tumor? Is this something? So oftentimes when women come to the office, and this is a common theme throughout this talk, we get a history, take note of her symptoms, and then do a physical exam, which we do gently, carefully, confidently in the office. And me and my assistant, my assistant's there with me while I take notes, or while she takes notes while I examine her, and determine, okay, what's coming down, whether it's the bladder or the rectum. Is it the uterus that's coming down? And a woman who's had a hysterectomy, the vagina may be the one that's coming down because the uterus is no longer there, or it can be a combination of all these areas, which is not uncommon in women. For pelvic organ prolapse, especially a woman who has pressure, a bulge, we may determine that she needs a pelvic ultrasound, especially if the uterus is still there, or the ovaries. Why? Because an enlarged uterus, an enlarged ovary, a cyst, there are different other gynecologic conditions that can cause pressure and these same symptoms. So oftentimes, if there's one thing we're going to get, would be a pelvic ultrasound to determine and rule out or rule in other reasons. So what are the options? This is very bothersome. It impacts women's quality of life and being able to do things. But some women, it may be mild. It may be early. Sometimes she may feel pressure. Sometimes you may feel, so the symptoms, oftentimes in the beginning, they wax and wane. And so some women may choose to see us. If it's a mild stage 1, it's just kind of a little bit the beginnings of, but not something that's apparent at the vagina, at the opening. Some women may say, let me just watch it and do pelvic floor exercises. There isn't the best data supporting the role of pelvic floor exercises or Kegel exercises to help treat prolapse. But I think it's a wise thing to do. The muscles that women would squeeze to stop the flow of urine, doing those Kegel exercises, a lot of them are familiar with being told that at least once at some point. Those are safe to do. It may prevent the progression of prolapse, maybe keep it from getting worse, but typically doesn't reverse it. And a lot of women have seen me, have said, Doc, I keep Kegeling, I've been Kegeling all my life and it's not helping, and that's not uncommon, that Kegels don't help for prolapse.
Dr. Tugbiyele, if I could
Yes.
interject just a moment, can we slow down just a little bit to make sure that everybody's catching everything you're saying?
Oh, sure, no problem. Yeah, that's
you.
I'll slow down. I won't go the New York Northeast speed. So,
Thank you.
Right. So as I was saying, and Joanna, on the screen, there's nothing showing on your screen, just the talk, right? There's nothing blocking.
Sorry, I was muted. No, it's fine. That recording,
Okay.
I don't know. Mine is up on the top left, so I don't know.
Mine is on the, and I'm not able to move it, but it's in a place where I can still give my talk around it. No problem.
Okay, yeah, but it's not showing.
Okay.
Yeah.
Wonderful. So pelvic floor exercises, either a woman chooses to do those exercises alone, with instruction, or some women may choose to see a pelvic floor physical therapist who we would refer a woman to. She would see that specialist once or twice a week for about an hour, typically over the course of 2 to 3 months. That will, and that coach, essentially a pelvic floor coach, will help a woman learn how to do her Kegels effectively. Because we find there are times when women think that they're doing Kegels, but they're not doing it effectively. They may be squeezing their abdominal muscles, their leg muscles, but not squeezing the exact muscles that need to be squeezed to help to support the pelvic floor and strengthen the pelvic floor muscle. And so those are two options. However, it's not uncommon that those are not helpful for the majority of women, as I mentioned. So a pessary is a device, and in my next slide, there'll be a picture of a pessary that I'll show you can help to support the organs and that we fit in the office or surgery. So the next slide, in the middle of the slide, you see a woman, you see a number of devices. There's one that looks like a donut. There's one that looks like a ring, and there's one that looks like kind of like a mushroom upside down. These are pessaries. These are devices that come in different shapes and sizes. They are made of silicone, and they go in the vagina similar to a diaphragm. Some women may remember that with contraception. And they essentially help to support the organs. And it stays in the vaginal walls and stays up there by suction, essentially. And so for women who have, mild to moderate prolapse, and in some cases, severe prolapse, these are notable options. When a woman chooses this option, we fit her for it. It shouldn't be too big that it hurts. It shouldn't be too small that it falls out. Just the right fit. So it's like I tell women, we're like shopping for a shoe. You may go into a store, you may find one that fits or not. So it's something that's worth a try, assuming a woman wants to try this and she hasn't tried one before. And when it's the right size, it stays in. A woman can then, it can stay in for as long as 3 months at a time. And then typically women would come in every 3 to 4 months to have it removed, cleaned, and put back. Why? Because it is a foreign body. And so we want to make sure it's not irritating the vaginal lining or and so on. But in some women, they choose to clean it more often. And in fact, that's helpful because it'll help to cut down on discharge or irritation or bleeding in some women. And so it can be removed at night or once a week or once a month, just kind of run under the sink with some antibacterial soap. And then we would teach a woman how to remove it, clean it, and put it back herself if she chooses. Again, some women choose this option, but I find that perhaps by the time a patient is referred to me as a subspecialist, they've either tried this or they may have decided that they perhaps are interested in surgery, but this is still an option that we offer. For women who choose not to be fitted with a device, why? Because it has to be removed, clean, and put back for intercourse, and there's a little bit more work involved. Some women then choose a procedure. So on the right side of the slide, I wish I could point, but on the right side, that's an example of one of the many surgeries that we offer, and it's a vaginal procedure. And this is a picture of a woman whose bladder has dropped. And so essentially what we do is we go inside the vagina, a woman's asleep, so she doesn't feel, see, or hear anything under anesthesia. We open up the lining of the vagina. The bulge underneath is where the connective tissue has stretched. And so we use suture material to tuck the bladder back up. We trim out the excess or redundant or stretched out vaginal tissue, and then we repair the remainder of the vagina back together again. We can do that for the bladder. We can do that for the rectum. If a woman has a uterus and the uterus is involved, there might be a potential where she may need to have a hysterectomy. Not all women who come and see us obviously need to have a hysterectomy with their prolapse repair, but for some women, if the uterus is falling out and exposed, then that would need to be the case. So that could be done vaginally as well, using suture material to tuck the vagina back up. Works well, high success rates, 80s, in the 80% range, and women do well with it, recover, go home, sometimes same day, and most women, if not same day, then overnight. Works well. On the right side of the slide is a picture of a standing patient where if a woman's tissues are not strong enough, if she's had prior surgery that has failed, perhaps using suture material and her own tissues, or if there's high-grade prolapse, meaning stage 3 or 4, where we believe that her tissues are not going to stand the test of time and she's really, really young and or very active, or just to paint a picture of somebody who's not sedentary, then there might be a need to do a procedure laparoscopically or robotically using a mesh. Now, when I mention that word mesh, I'm not talking about the 1-800 bad mesh or commercials, lawsuits, infections. I'm not talking about any of that mesh. Those procedures are, for the most part, no longer on the market. Those were procedures that were developed to have mesh placed inside the vagina to support the bladder. Like literally a mesh will be the size of my palm placed in the vagina to support the bladder or the rectum or the top of the vagina. And that's not the approach we're talking about here. Similar to what general surgeons do to fix hernias, we would place the mesh through the abdomen, through tiny incisions. And I've done close to 1,000 robotic procedures So tiny incisions, we place the mesh in the abdomen, and we use that to support the vagina. That lifts the vagina back up into its normal position. A woman's tissues grows in, through, and around it to provide that support. Long term, we're not relying on her tissues. We're relying on the mesh that kind of incorporates and becomes a part of her. And so the success rates are really, really high. And only board certified specialists really are qualified to really do this procedure to the excellence and the extent that needs to be done. 95%, 90 to 95%, depending on your the source of the literature, works well. Typically, this is the last procedure that women will need to help to support their prolapse, and it works well. Women can go home either the same day or the next day, and it works really well. So there are options. There are options. And so that explains prolapse, and then we'll just kind of switch gears. So, and I'll take questions at the end because I don't want to go too quickly, but I do also want to go through some number of slides here. So incontinence, that's the accidental leakage of urine, and there are different times when leakage can occur. Is it stress incontinence? Is it due to leakage of urine with laugh, cough, or sneeze, or jump, or lift, or exercise? I have a lot of women, moms or grandmoms, who say they can't jump on the trampoline with their kids or their grandkids because they may leak. That's stress incontinence. Or is it the leakage as a result of an urge, getting an urge and not making it to the bathroom on time? A lot of women may have seen commercials on TV that kind of gotta go, where, there's a sudden urge, rather than a gradually increasing urge, and she may have to get there in time. And some women leak as a result of not making it, but some women just make it there in time. Waking up at night to empty the bladder more than once, that all kind of is encompassed in an urge incontinence or an overactive bladder. Some women may have both. They may leak urine with exercise, with activities, and they don't make it to the bathroom on time. So we call that a mixed incontinence because they have the stress and urge incontinence. Overflow is where a woman may have had a condition, a nerve condition, where their bladder they don't feel a sense of fullness. They don't realize when their bladder is getting full. And so their bladder kind of fills and fills and fills and kind of spills over, kind of like a kettle, once it gets overly full. And sometimes we see this in women who may have a medical condition such as multiple sclerosis or some sort of a spinal cord injury, where the nerves that help to tell the bladder, I'm getting full, are no longer working. And that's also a neurogenic incontinence, where there's something wrong with the nerve, not just the bladder muscle, but the nerve, that women don't feel the urge to go, or they get the urge too quickly and too often. Bypass is a fistula, typically where a woman may have had surgery and then the urine is leaking through the vagina when it shouldn't be leaking through the vagina. So that's another issue. And so there are different classifications of incontinence. And so again, just like prolapse, when women come into the office, we get a thorough history, a physical exam. Depending on if she's emptying her bladder completely or not, it may require a renal ultrasound or a CAT scan to determine, okay, is it affecting the kidneys? Because if urine isn't emptying properly through the bladder, it in some cases can track back up to the kidneys, and we don't want to lose our kidneys because of an issue of which we can fix. So that's sometimes an imaging study that we get if it's indicated. And then back to treatment options. Depending on how a woman feels, again, we're quality of life subspecialists. And so if this is not bothering a patient, we can't help her. But most women will say no, they don't want to smell like urine. They don't want to wear a pad after they stop having periods. This is uncomfortable. So we tell women, you're not alone. There are ways to address it. You don't have to live with pads or liners forever. So Kegel exercises actually can be helpful for incontinence. Unlike prolapse that I mentioned before, this is a very effective strategy. Some women choose to do the Kegels by themselves, or again, like I mentioned, they may choose to be referred to a pelvic floor physical therapist. And if a woman's feeling better, good. She's happy, we're happy. But there are some women who may need to be fitted with a pessary, like I showed you in the previous slide, because these pessaries not only support the bladder, but there's some designed specifically for the urethra to help to support the urethra as well. But in women who choose not to have those options, they may choose surgery. There are different types of surgeries for incontinence. The one that's shown on this slide is a sling procedure that's specifically designed for stress incontinence, where there's the markings for the urethra, the vagina, and then there's that tape that's going underneath the urethra that helps to support the urethra to help maintain its normal position. So when a woman laughs, coughs, sneezes, jump, lift, exercise, trampoline, whatever the activity is, and in some women, intercourse. Some women leak as a result of intercourse. That can help to support the urethra. Success rates are good. This sling has been around in the United States since 1996. It's been available and works well. The success rates, improvement rate is into the 90% range. And so it's an outpatient procedure, 30 minutes. Women go home the same day. They're able to resume their usual activities within a few short weeks, and works well. So there are other procedures for incontinence, maybe a collagen injection, where women, we inject collagen to the urethra to help to support the urethra from inside, or you just using sutures to support the urethra. So many different options. For the urge incontinence, some women may be a candidate for a nerve stimulator to help to control the nerves that are overactive, or Botox that's injected into the bladder to help to calm the bladder down, to give women more time to make it to the bathroom. And a lot of women are familiar with Botox that is used cosmetically. What it does is, when it's injected into muscle, it relaxes the muscle. And when it's used cosmetically, it smooths out the appearance of wrinkles. When it's injected into the bladder, it helps to relax the bladder. Next condition is called fecal incontinence. That's the involuntary or accidental loss of stool. It's very, very common, but not quite talked about as often as urinary incontinence. It affects quality of life even more so because of the odor involved, and it's hard to hide it really. Has a negative psychological impact to your body image, can increase the risk of bladder infections. Imagine if there's stool around the opening to the vagina or the urethra, then that can lead to contamination and urinary tract infections. And it's really, really common, especially in women who are older or nursing home patients. And so just very briefly, it's a busy slide, but in terms of bowel movements, when it's time to have a bowel movement, the pelvic floor muscles should relax. There should be a valsalva, a bearing down, and the stool, then it leaves the rectum that's been stored in the sigmoid rectum and then is eliminated. But there are times when, if the muscles are weak and the rectum is not really supported well, the stool can leak or gas can leak. Or when a woman empties her bladder, she feels stool leakage, or when she thinks it's gas, but there's stool there. So there's so many different reasons, either due to the muscles, due to the nerves, or due to the mucosa, the lining of the rectum that's weak. Or there's some women who have constipation, where rather than their pelvic floor muscles relaxing, it actually tenses up. And so they cannot empty. And then they have to strain and force and bear down really hard to have a bowel movement. And their stool may be hard if it's backed up. And so we get into different ways that can be managed. For fecal incontinence or leakage of stool, again, same theme. We get a thorough history, physical exam. There might be times we may need to do an ultrasound to determine the integrity of the muscles. Especially in a woman who has had a baby recently, that she may have torn significantly, or maybe a episiotomy was done and the muscles are separated and they're not together as they were and should be. And so that may need to be addressed. There are ways that this can be managed conservatively, though. First, stool consistency. We make sure women are drinking enough water, especially if there's constipation involved. But if it's leakage, oftentimes getting enough fiber, getting more fiber is helpful. Pelvic floor exercises, either self-Kegels or with a physical therapist, can be helpful. Medications, Imodium is something that is over the counter that we prescribe that can help to give the stool more time to, how do I describe it? It helps with relieving the potential for incontinence by slowing down the gastrointestinal tract. There's some women where the stool goes too quickly through the gastrointestinal tract and it doesn't have time to really form, and it's liquid and then it leaks. So stool is easier leaked if it's liquid than solid. So the Imodium slows things down, so it's more formed, and women have more control. When it comes to surgery, depending on the situation, if it's a muscle separation issue, or if there's loss of support to the rectum, there's some situations where we may need to do a repair of the perineum, of the rectum, of the muscles that support the rectum, the sphincters. And so the diagram that you see in the middle of your screen is showing that type of repair using suture material, and that's a vaginal perineal repair. On the right hand of that diagram is a rectal stimulator. So the nerves that control the bladder and the rectum are similar, and there are ways that they can both be controlled or managed using a device or a stimulator that sends electrical impulses through a wire down to the nerves that control the bladder and the rectum. Very, very successful, high 80 to 90% range for fecal incontinence, even higher than urinary, which is more 70 to 80% improvement rate, but works well. And so it really can provide a way to stimulate, to get that muscle to function better and really relieve this very embarrassing and very distressing condition. So the other condition that urogynecologists manage are recurrent bladder infections, either an acute one that just popped out of the blue, or one that keeps happening and it seems like women can never clear it. So whether it's getting one UTI in a lifetime or every couple of months or once a year is not a big deal. It's not, I'm not downplaying it, it's bothersome and uncomfortable, but it's not a disorder. But if it happens more frequently, either more than 2 in 6 months or more than 3 to 4 in a year, then that could be a reason why, okay, is it because it's not being adequately treated? Or is it because the antibiotic choice did not address the bacteria? Or is it because she keeps getting back the UTI? So after it's treated, there's a relapse and it comes back. So there are different reasons. So we evaluate that in the office. The most common bacteria that causes UTIs in women is E. coli. So women anatomically are set up, unfortunately, for UTIs more so than men. Why? Because the urethra, the vagina, and the rectum are in close proximity. They're close to each other. So when the stool's there, or if there's a reason for a UTI, it's easier for it to occur in women than men. What are some of the symptoms that women feel? Burning, that's dysuria, burning with urination, urgency, gotta go frequently, maybe, and if it's far gone and hasn't been treated, even blood in the urine. So that's something that we want to treat quickly. What are some of the risk factors? Before menopause, sexual intercourse. Why? Because bacteria can find its way from the vagina into the urethra easier in women who are sexually active than women who are not. Depending on the type of contraception, spermicides, early menopause, can do it. Diaper use can do it. And any recent infection, a woman then is at risk for another infection. And for postmenopausal women, when estrogen levels start to decrease, that women can find that the vaginal walls are thin, the urethral lining is thin, and then there's not that barrier or that defense against a bacteria coming from the vagina and the rectum. The vagina has normal bacteria that already live there, many hundreds that live there. And when the estrogen levels start to decrease in menopause, it can affect that bacterial balance in the vagina, which then can increase the risk of the bad ones or the inappropriate ones getting to the urethra. Incontinence and pad usage, perineal pads, can also increase the risk of UTIs. If there's a prolapse, where women are not emptying their bladder completely, a history of surgery, so many different reasons. So we, of course, do that physical after getting an adequate history, maybe a CAT scan or ultrasound to rule out a kidney stone or some other issue. Part of what we do in women who've had prior pelvic surgery is to make sure there's not a stitch in the bladder or some sort of foreign body. So a cystoscopy is oftentimes done as part of that evaluation. But there are lifestyle changes that we oftentimes talk to women about in terms of decreasing risk of UTIs, like drinking enough water, making sure that, because a lot of women perhaps who have UTIs also have incontinence. And so they're cutting back on fluids to help to maintain, so that they're not in the bathroom all the time, but then that can lead to recurrent infection. So staying hydrated, 6 cups of water, doesn't have to be 12, but 6 to 8 cups of water is oftentimes considered adequate. Some women may choose to take a cranberry supplement, a tablet typically, or a capsule once a day. That'll help to make the urine less favorable for bacteria to grow. Emptying the bladder in a routine fashion and not holding it too long. Wiping, front to back. Every adult woman knows that, and has raised women and girls knows that. And so there are different things that women can do at home to help to hopefully reduce the risk of UTIs. Emptying the bladder after intercourse. These don't have like the major research studies, supporting that they are the be all and end all, but I think there are wise lifestyle things that women should be doing to help to minimize their risks. Medications, of course, if there's a UTI, then antibiotic is oftentimes helpful. And then there's some women who may choose a non-antibiotic option, and in very select situations, if a woman a woman has come to me and said, I want my body to clear it. Maybe it was over the weekend and they didn't really call us. So they did a whole, they took, some sort of preparations to help clear it. And in some situations that has helped her. And so we talk about that and see how that can be part of a holistic approach of addressing UTIs. And then reconstructive surgery, depending on what's the cause, if it's a bladder prolapse, a drop, or if there's a stitch or foreign bite in the bladder, then that would need to be corrected surgically in order to help to prevent the infections. We also manage pelvic pain. Pain is a very complex condition that affects many areas of the pelvic floor. And for women, it can affect the gynecologic organs, the bladder, the uterus, the ovaries, the muscles. Could be due to a prior pelvic inflammatory disease, endometriosis, pain, adhesions, cysts. If it's, or it could be gastrointestinal from the bowels. Is it due to irritable bowel syndrome or diverticulosis? It can affect the bladder. Is the pain coming from the fact that there's a urethral syndrome or interstitial cystitis? It can affect the muscles. So is the pain coming from the fact that the muscles are tense and don't relax? At rest, the pelvic floor should be toned, but not tense. And some women come to see me and they've had ultrasounds, they've had this and that, and no one's able to determine what their pain is from, but they have pain when they sit. They have pain with intercourse, and it's better in the morning, but it may be worse at night. And so I examine them, and if they have pelvic floor muscle tension, they may choose physical therapy or a muscle relaxant, and they feel better, and there goes their pain. Is it an injury to the back that may require physical therapy or treatment from another specialist, maybe an orthopedic specialist? And then psychological. There's some women who unfortunately have had either physical or sexual abuse, depression, anxiety, that may also impact their pelvic floor because they tense up in so many different ways. So this slide essentially just supports and confirms what I mentioned the last time, that pain is multifactorial and multi-location oftentimes. And so as urogynecologists, we really have the training to tease out where is the pain coming from and what's causing it and how do we treat it. It's not all the time that a woman has pain that, oh, it's due to a uterus and you need a hysterectomy. Or, that little cyst, that little 1 or 2 centimeter cyst in the ovary, that is not necessarily what's causing the pain. Is it the muscles? Is it the bladder? Is it the urethra? Is it menopause? So there's so many different reasons, and we take the time to determine exactly what it is so we can treat it and get you better. Excuse me. So with pain, again, after a history and physical exam, the necessary imaging, is it, treatment options that exist, physical therapy, there are medications, either muscle relaxants by mouth or muscle relaxants through the vagina that help to relax the muscles. There's some women who may need a nerve block or nerve injections to help to decrease the pain in the vagina. There's some women I've taken care of who've benefited from pelvic floor Botox, which helps to decrease the spasm and the tension in the pelvic floor muscles, and that's worked well. So switching gears, fistula. As I mentioned before, a fistula is an abnormal connection between the bladder and the urethra or uterus and the vagina. So there are some women who have what we call a vesicouterine fistula, where the bladder and the uterus are abnormally connected, maybe due to some sort of an injury from surgery or diverticulosis or some sort of pelvic infection. So then some women may have blood that comes into the urine from the uterus, especially if she's menstruating, and then she has blood in the urine as a result of the blood coming from the uterus. But more commonly, a vesicovaginal fistula is a connection between the bladder and the vagina. So vesicovaginal, and so urine goes from the bladder to the vagina, and so women are leaking through the vagina. There's also rectal vaginal fistula, where a woman's rectum and the vagina are abnormally connected, so there's stool that comes to the vagina. Or a urethrovaginal, where again, urine is coming to the vagina, but not from the urethra. So they're different areas. And these, of course, are unwanted things. And so this has to be addressed. In the United States, oftentimes it's due to a complication of pelvic surgery or a pelvic infection. In developing countries, oftentimes it's due to obstetrical or childbirth injury. So we determine what the case is and determine how to address it. We try conservative measures first. Some women may need to have a Foley catheter initially just to keep the urine from drenching them all the time. but then oftentimes this requires surgery to help to repair the injury. And we're able to do that with high success and really return a woman's quality of life back. So it's a slide. This is a slide that talks about voiding dysfunction, difficulty emptying the bladder. You know, it may be due to the fact that the muscle is weak, the bladder muscle doesn't squeeze well enough, or there's something blocking the opening that the urine can't go through, or it could be due to a nerve. The nerves aren't working. And so a woman's bladder fills, and then it just spills over, like the overflow incontinence we talked about. Or it could be a problem with a stool passage. So if there's a problem with stool passage, it may cause constipation. It may cause not feeling as if a woman's empty. Different reasons. It could be nerve, it could be muscle, it could be diet. And so we also manage these conditions, get to the root cause, and then get a woman better. Oftentimes, we may also have a woman see a gastroenterologist or a colorectal specialist because then we need their input as well. And so as urogynecologists, we're kind of a good centerpiece for the pelvis is the best way I can describe it, because we have training in so many different areas: the urologic, the gynecologic, the colorectal, the muscles, the nerves. So we're able to determine, okay, is this something that would needs a colorectal specialist, or needs a physical therapist, or needs a urologist, or needs a colorectal specialist? And we're able to then get the team together and get a woman better because of the byfactor of our training as urogynecologists. This is a very interesting slide. You know, type 4 stool is typically the gold standard, where it's, you know, cinched on both ends, a soft banana looking stool. But if there's difficulty with emptying the bowels, maybe inadequate fluid intake, or straining, or the stool just goes so slowly, a woman's bowels are really slow, then they get harder and they become lumpy, or they can become like a lumpy kind of surface sausage. But if the stool is going too quickly, or if she's eating something that's spicy, or that is causing indigestion, or highly processed foods, or dairy, you know, those things don't process really, really well in our gastrointestinal tract, and it may be watery and lead to more liquidy stools. So this is a graph that oftentimes women and us in the office can determine, okay, what's going on, depending on the type of your stool, just looking at the stool. The same pattern of getting a history, physical exam, imaging when indicated, and determining how best to treat this. Like I mentioned before, is it surgery, or is it medications, or physical therapy, or lifestyle changes? So as we wind down, there's women who see us due to complications of vaginal surgery or complications of childbirth. We get a history. Was there an episiotomy done? Was there forceps done? Was the labor long? Was it short, really quick, and the baby and the tissue didn't have time to stretch? Was there an issue with that hysterectomy that occurred, or was mesh used vaginally that occurred? And so, or was there bleeding or an infection involved? So there are different reasons that could have caused a complication that we take note in the history, and we determine based on a physical exam and other workup in the office. And then from there, we determine how best to treat it. Again, it's this usually a combination of lifestyle changes. It could be medications, pain control, physical therapy, or reconstructive surgery. On this slide, you see a pelvis of a woman who had vaginal mesh placed. And so there's times when it needs to be removed, or there's an area that's exposed. Maybe the whole thing doesn't need to be removed because it's holding things up, but just an area that didn't quite heal or became exposed recently because she's now in menopause and the tissues are thin. And so we repair that area, or there may be times when we have to remove an amount of it to help to restore pelvic floor function. Okay. So I know I went through a lot there, and I was speaking really quickly. Thank you for slowing me down there, Joanna. In terms of, so as urogynecologists, we take care of pelvic floor disorders, issues that affect women that are common and impact quality of life. There may be more than one system that's involved with the pelvic floor. It could be, again, as I mentioned, gynecologic, urologic, colorectal, the nervous system, the muscles. So we determine exactly what's the issue. As I mentioned, yes, body image is a significant concern, because a woman wants to feel like a woman. They want to feel, you know, attractive to their spouses, or to just want to feel like a woman, and they want to feel beautiful for themselves. And oftentimes these disorders get in the way. And as urogynecologists, we reassure women that there are several safe and effective options that can improve a woman's quality of life. Our training is unique. We did, for example, I did OBGYN training, so 4 years of obstetrics and gynecology. I don't deliver babies anymore. I then went on to the University of Maryland to finish a 3-year fellowship at Greater Baltimore Medical Center in Maryland to finish subspecialty training, so 7 years. And so it's really important for women to know the right place to go to. If she's having a pelvic floor disorder, in my opinion, the best place to go to is a female pelvic medicine and reconstructive specialist who knows, and a urogynecologist who knows and has had the training to determine the root cause of the issue and tackle it and get it improved, so women can benefit and move on with their lives and really enjoy the lives they want to live. So this just echoes what I just essentially mentioned. And this is one of my last slides. So if a woman is interested in seeing me, it could be just to maybe talk about their symptoms. A lot of women have come to the office, seen me, and decide, okay, I'm going to do some more research, think about it, and that's fine. Or a woman may say, this has been bothering me. I've been thinking about it for years, and it's getting worse. I need something done. And so we do reassure women that we do have a number of options that are safe and effective. Thankfully, for women who chooses an office-based option like a pessary or medications or surgery, insurance does cover it. So a lot of women do come and see us because they know that their insurances are there for that and that it covers it. Towards the end of the year, typically we see a lot of women because they say, oh, my deductible's running out and I've done all the things I need to do, and they want to do like more elective things towards the later part of the year, and that's fine too. While this is elective, it's not cosmetic. So we do reassure women that oftentimes, typically, these procedures are pre-certified by my surgery scheduler and approved by their insurances. So there's nothing to lose there. And after just a few short days, whether it's days or a few short weeks, women are able to return to their normal activities. Some women now, especially in this day and age now, a lot of women can work from home while they're healing, as long as it's something sedentary, they're not lifting too heavy. And so a lot of women do choose to have the surgery and heal from home or go back to work in a few short days or weeks, depending on the type of surgery they had. Of course, limiting initially their activities until they're able to resume their usual activities, which isn't too long, and really then be able to benefit from that for their lifetime. So we are here to help women. And we lay out all the options on the table. Women choose what's best for them, and we love to see a happy face. And then she then tells the rest of her friends who are having it, just not talking about it. And so that kind of winds down my talk. If anyone who's looking for more information, our website is www.northsidecenterforurogyn.com. That's Northside Center for Urogyn.com. So you can go to the website. My bio's there. A lot of information's there. Also some notable links to get additional information out there. That's the office phone number there. I'm in Lawrenceville. I do see patients there primarily, but I work at the Northside Hospital and Surgery Center facilities for women who choose to have surgery. And oftentimes we're able to treat a woman closer to home, whether it's in Forsyth or in Gwinnett County or in Atlanta or in Cherokee. So we're able to really cater a woman's surgery that way. And I think that pretty much wraps up all that I wanted to mention. And thank you so much for your attention. I apologize for going quickly there, but wanted to make sure we were able to get all that information. Hopefully this has increased value. This has been valuable information for you and increased your awareness of these conditions and the benefits of a urogynecologist in a woman's life. And so if there are any questions, Joanna, I'm happy to take them now.
Awesome. If you have any questions, feel free to unmute yourself, please, and just chime right in.
Yes, it was an excellent, full discussion. My cousin and her sister have the pessary, and then I've been asked to get the mesh tightening of the bladder, and I'm scared. Right. And I've been to one of the few specialists who do the exercise for Kegel.
Right.
She was one of the few in the South, and so I know the full exercise for that. And
right.
Thank you for everything. And I'm coming for help.
Oh, you're welcome. You're welcome, Sharon. We'll talk about just like I do with my patients, we talk about the options in the office. And again, there's so many different caveats depending on a woman's history and what can be done, mesh, no mesh. There's so many areas that we can't even get into all the specifics, obviously here now, but we'll talk about it in the office and look to get you better.
Excellent, full presentation. Is this video available for me to show that cousin? Because she's having a lot of the problems that you mentioned.
Yes, I record all of these, and then following the presentation, I do email that out. I will, you know what, I'll share my screen. That way you have my email address, and feel free to, if you don't already receive my emails, feel free to email me. And then that way I can get you the information.
Okay, or if you put anything in the chat, I'll screenshot it right quick.
Yep, give me 1 second. I'll see if I can do this for me. Oh, yeah, I can do it in the chat. That might be a lot easier, wouldn't it?
Well, I'm putting my email in there for you.
Any other questions?
I just have one quick question. I know you mentioned strenuous activity. Is that like something onset, like lifting something heavy, maybe while moving, or for instance, I like to lift weights. Is that something that I should be more conscious of when I'm working out, the type of weights that I'm lifting and how much I'm lifting?
That's a very good question. So, on the one hand, we want women to be healthy, right? So working out, staying active and physically fit is important. Why? Because that helps to maintain a normal body weight. I like to tell my patients that, there's certain things in this life that we cannot control. No one's getting younger, we're all getting older. We can't reverse the hands of time. There's gravity on this era, and a lot of women choose to have children and, can't control how that whole process works out. But there are certain things that we can control. And one of them is avoiding constipation, right? Avoiding heavy lifting and maintaining ideal body weight. So working out is part of that, maintaining ideal body weight. So that's important, but there's a way to do it. You're right. To help to put the pressure of the weights and the working out should go on the bones and the ligaments. It's hard for us to control that, but what that means is we have to maintain a normal and a favorable posture. Because if we're, depending on how we're leaning, maybe too forward or back, or if we're holding our breath and lifting something heavy, then we're putting pressure on the pelvic floor. It's like doing a Valsalva. It's like kind of bearing down for bowel movement each time you lift something or do a deadlift, depending on what you're doing. And I have a lot of patients, just like myself, I like to do HIIT training at high intensity. So it's all about the form. So making sure that the pelvis is tilted in a way that it's not taking the brunt of that weight. Dumbbells shouldn't be an issue as long as we're not holding our breath and doing it, because if we're holding our breath and bearing down and scrunching, then that can be an issue. The way we do crunches, there are ways that can do it that just exercise the abdominal muscles and not bearing down. So it's just a matter of being conscious of the form, making sure that we're not putting pressure on the pelvic floor. Sometimes seeing when a woman comes and sees us, we may suggest referring to a pelvic floor physical therapist or exercise physiologist. So somebody who can watch you and see what you're doing, and then also help us to determine, okay, when you're doing that exercise, do it this way, not this way. When you're lifting that dumbbell or that weight, do it this way, not that way. So it's not a matter of just giving up everything that you're doing, but a matter of the right form. Now, with patients, for example, when patients say, Doc, what should I be doing? I tell them, well, there is no magic number. However, right after surgery, we tell women to restrict from lifting anything above 10 to 15 pounds. So a gallon of milk is about 8 pounds. And so that's just a rough guesstimate. And then after that, we say, well, lift your grandchildren, please exercise and enjoy your life. But, furniture, if you're lifting furniture every day, like something on the orders of furniture, big clay pots, I'm just kind of giving a picture. If there's someone else who can lift those things, then I tell my patients to have them lift it. Either that's a paid source or whoever. I just think that a woman needs to be very mindful of how much heavy lifting she's doing, because over a lifetime, that can increase the risk of prolapse and things not working well. Right. Okay. So hopefully that answers your question. Live your life, but just be mindful of your form. And if there's anything strenuous that's going to make you like you're really exertional, if that can be done by somebody else, do it. I've had patients, they said the prolapse happened after they did the move, and they did the move by themselves. So I was like, well, those heavy boxes did it. But if a grandchild, or if you need to, you have to live. So there's a balance to be struck there.
Okay. Thank you.
My pleasure. You're welcome.
I also have a question. You mentioned about doing a pessary and also doing a mesh of surgery. Now, if you do a pessary, how long can you keep the pessary in your body? Do you have to, you mentioned like you clean it either every week, every month, or whatever it is.
Right.
But do you have to replace the pessary?
That's a good question. Right. So a pessary is it's a device that goes in the vagina, and in my experience, and I've been doing this for 16 years and counting, oftentimes by that for women who's chosen to use the pessary long term, after 3 and clearly by 5 years, the pessary looks worn, it may look a little discolored. So oftentimes a woman at that point who decides to continue using a pessary, we swap out the pessary for a new fresh one, so to speak. But in terms of how long it could be worn, it needs to be cleaned either by the patient or by us periodically, as I mentioned. But it could be used for as long as the woman chooses to use it. There's really no limit to the years or months or so. I've had patients who say, I want to use this and that's all I'm going to use. But I've had also patients say, I'm just going to use this for now. I want surgery, but just not now. Maybe in the summer when I'm off, or work or family or kids, whatever the situation is, but they're using the pessary temporarily until they have a procedure that they choose. Or I've had patients say they leak only with strenuous exercise, only when they're running, only when they're in the gym. So they wear a pessary just for that, and then not anytime else. So it really, really depends, especially if it's for incontinence. If it's for prolapse, when the pessary is not in there, everything's gonna sink down. So there's no time limit. Some women choose to use it for weeks, some months, some years, and they're fine. Other women use it for a short period of time and then have surgery. What I tell women though is if you're planning to have surgery, I wouldn't wait years to have surgery, several years. Why? Because, I tell her, I say, you're not getting younger, I'm not getting younger. So the younger a woman is, the younger a patient is, generally the safer it is. So if a woman's gonna ultimately have surgery, I wouldn't wait many years, but it doesn't have to be done immediately. This is a quality of life issue. It's not life-threatening, so it's not an emergency. So this can be planned. And so some women choose to use a pessary while they're planning their life. Other women tell me, nope, they want surgery and they want it yesterday because they've waited enough and they don't want the pessary. So everyone's different.
I have a question. Can you hear me?
Yes, I can.
And thank you. Fantastic presentation.
I appreciate that. Thank you.
For an older woman who has a large belly and she has almost no strength in her lower back, and she often has back aches, does that contribute to all of your functioning in the lower part of your body? Does that contribute? And is there something she should be doing to make things better? I mean, trying to get rid of the belly surgically is out of the question. So I don't know what else to do.
Okay, that's a good question. Right. So you're right. There's some women who surgery is an option, and that's a quicker means to the goal. But weight loss, progressive weight loss, and I've known women who've done it slowly over time, but successfully, and they've been able to keep it up because they did it at their pace, whether it's weeks, months, or years. But yes, decreasing obesity has been associated, or being overweight is associated with prolapse and incontinence. So when a woman loses weight, yes, her pelvic floor function will be better. So yeah, so and the pressure on the back will be improved because there's not that weight that the back and the skeleton and our pelvis has to bear up, right? And so our bones, ligament, and muscles all support the pelvic floor, like I mentioned, and the organs. So when there's less weight that we're carrying, then the muscles below are able to then support things better from below, so that there's less risk that the organs will give way because of the weight, if that makes sense.
Yes, thank you.
My pleasure, you're welcome.
Dr. Tugbiyele, there's another question from the chat. Is there a nerve stimulator device for overactive bladder for purchase that like just a normal everyday person can go get?
Not for purchase. Let's see, what's available for purchase is online, these Kegel balls, which they're weighted kind of balls that women can purchase, and then they some women I've seen placed it in the vagina, and then gradually it's they are able to determine, okay, how heavy a Kegel ball can I hold? And so they go from the lightest one they can hold in and squeeze around to help with their pelvic floor exercises at home in the privacy of their home, and then slowly graduate to the heavier ones. So when a woman purchases them, she purchases a number of them, going from the lightest to the heaviest. And then over time, it's a way of training the pelvic floor muscles to hold the ball in for longer periods of time and strengthen the pelvic floor muscles. So that's available, but not so much so the nerve stimulator that I mentioned in my talk. In fact, and there are two different nerve stimulators. I just want to touch on them very lightly. There's one in the office that we use to treat an overactive bladder. So women come into the office, we stimulate the nerve in the leg, and the leg nerve is connected to the nerves in the pelvis. So when we stimulate the nerve in the inner aspect of the ankle, it then transmits that signal to stimulate the bladder nerves, which helps to control the overactive bladder. So women would have to come into the office for an evaluation, determine if that's the option that's best for her, and then we would schedule that in the office, 30 minutes once a week, and insurance covers it. Or the way we can directly stimulate the nerve is by placing a battery and a wire down through the back to through the spine, not touching the spinal cord, not touching the nerves, but just gently stimulating very close to the nerve that controls the bladder and the nerves of the bladder and the rectum. But that has to be placed surgically and not purchased over the counter, so to speak.
Okay. And then one last question I saw on there. Are there other pelvic floor exercises that you would recommend? Or is that something that somebody would get at like a physical therapy session?
Right. So when patients come into the office, we tell them about doing the Kegel exercises, the muscles that you would use to stop the flow of urine or stop gas from coming out. Yes. So those are those, and that helps with urinary and unwanted stool and or gas leakage. But then when a woman sees a pelvic floor physical therapist, they also assess the muscles of the lower back and the anterior abdomen and the pelvis, and coach a woman on how they're doing. So not only do we say, oh yeah, do your Kegels, but they're able to have equipment that tests the muscle strength and tests if it's getting stronger or staying the same.
So in terms of doing something at home, then it's really Kegels.
Yeah, at home is really Kegels. Yeah, essentially.
Okay. All right. Are there any other final questions? I know we're up against the time here, but if we have one last question, we can certainly chime in. Well, I don't see any. Thank you guys so much for joining us. Thank you, Dr. Tugbiyele.
Thank you.
Yeah, for sure. If any of you saw, I did post my email in the chat, but if you didn't catch it, it's just joanna.phillips at northside.com if you would like the presentation to be sent to you, or if you'd like just to be added in general to our email list, I can certainly do that. I did make note of those of you who did request the presentation, and I will add you to my email when I send that out tomorrow. So thank you again. We hope you'll join us for our future presentations. And with that, I hope you guys have a wonderful day.
Thank you.
Thank you. On behalf of the
you.
Dorothy Benson Senior Center, we thank you.
Thank you so much. Share this with family and friends. Share the video. Thank you so much. I appreciate it. Thanks for your time.
Thank you.
We appreciate it. Thank you.
Thank you so
My
much.
pleasure. You're welcome. Have a great rest of the day.
God